Next, let's discuss Gestational Diabetes Mellitus, or GDM, which is a condition that arises during pregnancy, characterized by elevated blood glucose levels that were not present before pregnancy. The root of this condition lies in the changes that occur in the mother's body to support the growing fetus. One significant change involves the secretion of human placental lactogen. This hormone increases insulin resistance in the mother, ensuring that enough glucose is available for the developing fetus. However, when this balance tips towards excessive maternal hypoglycemia, it leads to fetal hypoglycemia and subsequent fetal hyperinsulinemia. In the first trimester, maternal hypoglycemia can have profound effects on the developing fetus, leading to congenital anomalies such as congenital heart disease, neural tube defects, small left colon syndrome, and even spontaneous abortion. As the pregnancy progresses into the second and third trimesters, the implications of fetal hypoglycemia and hyperinsulinemia become more pronounced. The increased metabolic demand can lead to fetal hypoxemia and an increase in erythropoiesis, resulting in polycythemia. Additionally, there is an increase in fetal fat and glycogen stores, which can cause macrosomia, a condition where the baby grows excessively large. Macrosomia brings with it a host of potential complications, including shoulder dystocia during delivery. This can result in brachial plexopathy, clavicle fracture, and perinatal asphyxia. Furthermore, the excessive insulin can lead to neonatal hypoglycemia, organomegaly, and hypertrophic cardiomyopathy due to glycogen deposition in the interventricular septum. Next, let's discuss the risks associated with GDM. These risks extend beyond the fetus. The condition also poses significant risks to the mother, including an increased likelihood of prematurity, respiratory distress syndrome, and complications during delivery. Laboratory findings in infants born to mothers with diabetes often include hypoglycemia, polycythemia, low iron levels, hypercalcemia, hypomagnesemia, and hyperbilirubinemia. Screening for GDM is crucial and typically occurs between 24 and 28 weeks of gestation. Women with risk factors such as obesity, GDM in a previous pregnancy, or having had a prior macrosomic infant may benefit from earlier screening and rescreening later in pregnancy if the initial results are negative. The screening process involves a 1-hour 50-gram glucose challenge test followed by a 3-hour 100-gram glucose tolerance test if initial results are abnormal. Management of GDM begins with dietary modifications. A low-carbohydrate diet combined with small frequent meals can help manage blood glucose levels. However, if glucose levels remain consistently above target, specifically fasting levels above 95 mg dl, 1-hour postprandial levels above 140 mg dl, or 2-hour postprandial levels above 120 mg dl, pharmacotherapy becomes necessary. Insulin is the first-line treatment because it does not cross the placenta and allows for adjustable dosing. For those who have difficulty with insulin administration, oral medications such as metformin or glyburide are alternative options. Postpartum management is just as crucial as managing GDM during pregnancy. Monitoring fasting glucose levels within the first 24 to 72 hours and conducting a 2-hour 75-gram glucose tolerance test at the 6 to 12-week postpartum visit helps ensure that the mother's glucose levels return to normal and that any lingering effects of GDM are addressed. Now, let's illustrate these points with a real-life case study. Imagine Sarah, a 32-year-old woman with a BMI of 30, who presents to her OB/GYN at 26 weeks of gestation. She has a history of GDM in her previous pregnancy and delivered a macrosomic infant 2 years ago. During her routine prenatal visit, she undergoes a glucose challenge test which returns abnormal results, leading to a subsequent glucose tolerance test confirming gestational diabetes. Sarah's healthcare team immediately initiates dietary modifications, recommending a low-carbohydrate diet and frequent small meals. Despite these efforts, her blood glucose levels remain elevated, necessitating the introduction of insulin therapy. Throughout her pregnancy, Sarah is closely monitored with regular blood glucose checks and adjustments to her insulin dosage as needed. At 38 weeks, Sarah goes into labor and delivers a baby boy weighing 4.2 kilograms. The delivery is complicated by shoulder dystocia, but quick action by the medical team results in a safe delivery. Post-delivery, the baby is monitored for hypoglycemia, polycythemia, and other complications. Sarah's blood glucose levels are checked within the first 48 hours and again at her 6-week postpartum visit, ensuring they have returned to normal. This case highlights the importance of early detection, appropriate management, and close monitoring of both mother and baby to mitigate the risks associated with gestational diabetes mellitus. Thank you for joining us on this episode of Med Madness. We hope this discussion on gestational diabetes mellitus has been informative and insightful. Stay tuned for our next episode, where we'll continue to explore critical medical topics to help you on your path to medical mastery. Until next time, stay curious and keep learning.